A very good afternoon to everyone. On behalf of Walter Kluwer, a warm welcome to our speaker and attendees of this webinar series, Medical Edge. Our topic today is stroke in young. Learning objective of this topic from today is define stroke in young, list the causes of stroke in young, discuss common causes with case-based scenarios, and overview the diagnostic and therapeutic options. And our speaker today is none other than Dr. Archit Gulur, who is Additional Professor of Medicine, Kasturba Gandhi Medical College, Bangalore, under Manipal Academy of Higher Education. Also, we'll be taking all questions at the end of the webinar, and I request you to please post all your questions in the Q&A panel of this event. We will try to address the maximum questions at the end. Please also provide a valuable feedback via link, which we will post in the chat section of the webinar. Now we begin our session, and I hand over to Dr. Archit and request you to please start sharing his screen. Dr. Archit, you can start sharing your screen, sir. Yes, sir, your voice is not coming through. Yes, sir, we can see your screen, sir, but your voice is not coming through. No, sir, we cannot hear you actually. Sir, are you using any speaker or a mic? Yes, sir.
Okay. So good evening, all. Today, in today's webinar, we are discussing a very important topic, an upcoming topic, that is stroke in young. As you know, stroke is a very common disease which is traditionally seen in elderly. We see it above the age of 50 or 60. And what we are seeing of late is we do get a lot of cases of stroke in younger patients. Okay? So younger than 40 years of age, and sometimes even in 20s and 30s, we are getting a lot of strokes. So stroke by the disease itself is the same, but possibly the etiology and the approach is little different, and that's what we'll be trying to discuss in today's session. So the overview of today's session will be discussing basically the epidemiology, the etiology, and then we'll discuss a few of the cases and if time permits, an overview of the approach of how do you manage stroke in young. All of you know the definition of stroke. So stroke per se is a clinical syndrome which is characterized by the features of either cerebral, spinal cord, or retinal ischemia, which lasts for more than 24 hours. And if it recovers within the first 24 hours, we call it as TIA, which should not only recover, even the imaging should not show any evidence of infarction. So it's important to know, even if the entire process recovers within 24 hours, but the imaging shows any evidence of ischemia, we would not call it TIA, we will call it as stroke. So without any acute infarction, only then we call it as TIA. Latest definition of TIA, the time frame has been reduced to less than 3 hours. So that's the definition. The definition remains the same for the traditional stroke as well as stroke in young. So as I told you, the new definition of TIA, which is not very new, it was described as late as 2002, where they said that it should be lasting for less than an hour, because all of you know that the first golden hour for stroke is 3 hours. So if you don't do the thrombolysis or a thrombectomy within 3 hours, we would maybe not be able to salvage the neurons. So if you wait for 24 hours for it to recover and then label it as stroke, it would not be of any much use for the management. So the new definition would decrease the TIA for lasting for less than an hour. So this is not yet come into textbooks, but still this is the definition, which is the working group definition. So as all of us know that it is one of the leading causes of death as you age, the second most leading cause of death after coronary artery disease as far as medical diseases are considered. And The third leading cause for disability adjusted life is the dailies that is lost. Every minute we have 30 new incidences of stroke that's happening, and as we know, the further the time in progress, the deficit, the recovery chances are much lesser. The deficit would remain. What is alarming is almost 10 to 12% of the strokes occur in young, and by young, again a varied definition. Many of the literatures say less than 45 years, but the consensus as of now says that it should be less than 40 years of age to call it a stroke in young. It is on the rise. I think I'll show it in the last slides where we have our latest data coming up, and I'll show you what are the percentages in that time. So if you see uh, by the year 2030, it is expected that we may have more than 200 million Delhis lost, and we may have more than 70 millions who are surviving stroke. So it's a disease which is increasing in number, possibly because of the risk factors that are involved. So basic classification of stroke is same. You have a primary ischemic and primary hemorrhagic. The primary ischemic could be a thrombotic or an embolic, and thrombotic could be an arterial, or it could be due to mechanical obstruction or maybe severe hypotension. Embolic arising from cardiac or from arteries. And you have the third category that you have to remember, which actually is a thrombotic itself, but it is the inflammation of the vessels. Now, it's important for us to note this because as in younger patients, if you see the arteritis being a etiology is much higher compared to elderly patients. Also, the embolic strokes are much commoner in younger patients, and the source of embolism in younger patients is cardioembolic. In contrast, in the elderly, the source of embolism is atheroembolic. Thrombotic strokes are common in young, but again, the etiology of thrombosis that we have to understand is different. In younger patients, when they develop thrombosis, it is most often a prothrombotic state, either an inherited or an acquired prothrombotic state that is the cause. Coming on to hemorrhagic stroke, if you see, you could get hypertensive hemorrhage. By far, the most common cause of non-traumatic hemorrhage brain is hypertensive. But again, remember, hypertension is not so common in young, unless you have secondary hypertension. You could have aneurysmal rupture or bleeding from the AV malformations, which are common. Also, as you age, cerebral amyloid angiopathy is one of the most common causes. In youngers, we do not find amyloid angiopathy as a cause. So the general consensus way back in 97, this was again updated in way back in 2003, but this still remains the traditional risk factors of stroke. You have hypertension, diabetes, atrial fibrillation, structural heart disease, sickle cell disease, cigarette smoking, alcohol, and obesity as an important modifiable risk factors. All of these can be modified. We can control them and we can prevent the strokes. The non-modifiable risk factors is the age, male sex, the African American race, the previous stroke, and the family history of stroke. So these are the traditional risk factors for stroke. Even now, these are very well important. We have the upcoming risk factors, which we'll be discussing shortly. So majority of the strokes, even in young, are ischemic itself. So if you see the classification, it still remains thrombotic predominantly. You could have the lacunar infarcts, which is coming to 20%. And then you have embolic strokes, which are accounting to around 15 to 20%, and others like vasculitis, etc., occurring to around 10%. Hemorrhagic, you could have 15 to 20% could be intracerebral hemorrhage, and around 5 to 6% could be due to subarachnoid hemorrhage and AV malformations. A very important point that we have to understand is, despite of evaluation thoroughly and with all the newer investigations that we have a large chunk of diseases where we can attribute it to either thrombotic or hemorrhagic or an embolic, but we are not able to attribute the actual cause. We may not be able to say this is the prothrombotic event or this is the source of embolism. And that percentage, if you take the entire number of strokes, almost around 30 to 35% of strokes, etiology wise, still remains something called as cryptogenic, where we are not able to localize the particular etiology. So that is a major cause of strokes, if you say cryptogenic, though it could be thrombotic. And of late, due to more and more advanced evaluation and understanding, a very important etiology that has come up as one of the commonest cause of strokes, both in young and adults, is what we call it as the PFO, the patent foramen ovale, which traditionally was believed as having no functional uh, abnormality. But now, through various evaluations, it has been proven that PFO is associated with a large number of stroke, embolic strokes, and that is one of the leading causes of the cryptogenic stroke. So young stroke, as various studies have been defined, uh, this is the last of the definitions in 2016, the Journal of American Heart Association, which described it, where they said that we have to give particular importance to younger people because it's very important that stroke does not cause death alone. Stroke causes a lot of morbidity, and younger patients do have a large amount of years into them, and the morbidity they have to live with has to be considered. That's why we have to specifically look into this part of young stroke, because we have to make sure that we have to understand the etiology, we have to narrow down the possible etiologies, prevent the recurrence, because if we do not correct the etiology, the chance of recurrence would be much higher. And as I told you, even with best of investigations, we would not be able to localize the cause in almost 50%. And if you treat it adequately, sometimes, especially vasculitis or AVM or something like that, you could get very gratifying results. The patients can have very good recovery. And also, the stroke may be a manifestation of an underlying systemic disease, especially in elderly, could be vasculitis, connective tissue disorder or something, and that could be the harbinger. So we may have to evaluate it thoroughly. So that's the importance of that. Various studies have been studied, and if you see in Indian studies, way back in 1970s itself, we have a large number of studies that came up from Vellore, which said that 25% of the strokes that were prevalent were in young. And the big studies that came from Karnataka, that is the Gauri Devi et al., they also said the prevalence was around 25 to 30%. And later, as the bigger registries came up, percentage of stroke in young rose. Okay, you have the JIPMA registry, which came up, had a large follow-up, and they said it's as high as 36.2%. So 36.2%, that's a high prevalence of stroke in young. Majority of the stroke in young, again, is ischemic there, and that's what you can understand. So various studies have come up to 2009. We have a few more studies that is coming up, which I'll be showing it the global burden, and that I'll be discussing it in the last slides there. The percentage is as high as 30% of the general stroke. So we have to address this because, as I said, longevity is important there. Now, as I've told you, the embolic strokes are much commoner. The cardioembolic strokes are very common in young patients. And in India, the rheumatic heart disease still prevalent, the atrial fibrillation still prevalent, are by far the most common causes of cardioembolic stroke that we look at in younger patients that we see. Patent foramen ovale, please remember this is an upcoming topic, and this is eventually going to be possibly the largest chunk of strokes that is going to come is due to PFO. We have studies that are coming up, and maybe in a year or so there will be a big publications of that, and we will have to screen a large amount of patients with the transesophageal echocardiography. The myxomas, not so common. Acute MI in young patients is less common. Mitral valve prolapse is associated with strokes, and the septal defects are also associated. The second important etiology, pretty common in younger patients, is the vasculitis. Infections producing the vasculitis. Very important is the tuberculosis, syphilis, and HIV. All three are common. Syphilis, though, not tested that much now, but it is common. Tuberculosis and HIV are two important vasculitis which can produce stroke. Apla syndrome, very important. Young lady with recurrent abortions, venous thrombosis, arterial thrombosis, that's Apla. SELI is associated with that. Wegener's polyarteritis also can be there. The less common ones, as we said, the thrombotic strokes, which are commonly seen in elderly. But in young patients, if you get thrombotic strokes, we have to look out for the prothrombotic state. By far, the most common one we encounter in India is the hyperhomocystinemia. The factor V Leiden mutation, the protein C, protein S deficiency. Migraine is associated with strokes. patients with polycythemia, essential thrombocytosis can also be there. You can have familial strokes like the cadacil and the caracil, and less commonly we do have familial hypercholesterolemia in India, not very common. Hyperthyroidism can be associated with strokes. We have had a few case reports which have been coming as the association of hyperthyroidism with stroke. The hemorrhagic strokes, AV malformation by far the most common. Bleeding disorders, anticoagulant usage. Cocaine abuse is one of the important upcoming. You see young hemorrhagic strokes in 5 years. Cocaine abuse is an important thing. Moyo-Moyo syndrome, we'll discuss that. It is a arteriopathy common in India, one of the important causes of hemorrhagic strokes. Other than arterial strokes is the venous strokes. Very classically, the venous cortical venous thrombosis, that's common. Very common in our subcontinent, especially in the peripartum region, the postpartum region that's there. Or if a patient has dehydration, patients, if you see, other than the postpartum and the pregnancy, please remember dehydration, whatever be the cause of dehydration, be it diarrheas or maybe any condition where there is an intravascular volume depletion, you could get strokes, which are venous. And oral contraceptive use is associated with that. And have the Apla syndrome, which I discussed, is associated with that. And connective tissue disorders can also be associated with venous stroke. So this is a little different, where venous strokes is one of the strokes where we have to give anticoagulants. Okay? Other than embolic strokes, venous strokes is the strokes where we give anticoagulants, which are traditionally not given for arterial strokes. So as I told you, the various percentages, if you could see by varieties of the studies, you could make out that the majority of the strokes in young are still ischemic. The embolic versus arterial atherothrombotic are almost the same. If you see elderly patients, if you have 10 cases of stroke in the patients above the age of 65, 8 of them will be thrombotic and 1 embolic and 1 hemorrhagic. But when we see a younger patients, okay, 30-year-old patients coming with stroke, if there are 10 patients, almost 4 of them will be thrombotic, again 4 of them will be embolic, and maybe 2 of them will be hemorrhagic. All of them is different. Okay? And as I told you, almost around 30 to 40% could still be undetermined etiology. So cardioembolic stroke is by far the commonest in the Western literature as well as in India also. The cardioembolic strokes are by far the most common strokes as of now. And if you add on PFO to that, they will become the most common. Okay? So embolic strokes are the most common strokes if you see in younger, especially if there is no prothrombotic state. Atherosclerosis, early atherosclerosis, or if you see patients who have drugs like oral contraceptive pills, or if there is a polycythemia due to whatever cause, you could still get thrombosis. Very important to understand, the pathophysiology of both of them would remain the same, but the etiology is different. So hematological conditions have to be evaluated. In India, we still have a lot of rheumatic heart disease, infective endocarditis, mitral valve prolapse is common world over. Atrial fibrillation, by far the most common cause of cardioembolic stroke world over. You could get the myxomas rarely. Post-MI clot that can also be dislodged. Sometimes cardiomyopathies, especially the dilated cardiomyopathy, can have mural thrombus and that can cause embolic stroke. As I've already told you, the patent foramen ovale also is a very important cause of cardioembolic stroke. So the heart and the brain phenomena, what we call it as the smoking gun phenomena, multiple emboli are released and they can go and lodge at multiple territories and cause infarcts. The non-cardiogenic embolic strokes could be from the pulmonary AV malformations. Okay? That could be the source, and the venous thrombosis can cross the PFO and come there. A specific entity that we see almost commonly in young patients is the non-atherosclerosis arteriopathy. That is, there is arteritis, inflammation of the vessels, which could be due to various causes. Younger patients could have Takayasus, you could have Churg-Strauss disease, infections like syphilis, TB, and HIV. These are 3 very rampant tuberculosis and HIV are very, very common in India. We do get it. Drug-related, cocaine, amphetamine, heroin, you could get, and the connective tissue disorders like lupus and polyarthritis nodosa. The non-inflammatory arteriopathies, again, some of them are very common in India. The one is the moyo disease. Sometimes you could have carotid or vertebral artery dissection. Post-radiation, somebody has undergone a radiation for lymphoma, a neck radiation for squamous cell carcinoma of the neck or something, they can be associated. Fibromuscular dysplasia, which causes renal artery stenosis, can also cause the same thing. And certain diseases are associated with fibrinoid vasculopathy. These are the non-inflammatory causes of arteriopathy. Hyperviscous stents, common like CML, myelomas, and leukemias, are also commonly associated with stroke. Polycythemia, be it primary or secondary, and the ones which we discussed already, the protein C, S deficiency, antithrombin 3 deficiency, DIC, antiphospholipid antibody syndromes, all of them can be associated with stroke. Thrombophilias are associated with both venous and arterial stroke. Thrombocytopenias are associated with hemorrhagic stroke. Few words about certain inherited stroke syndromes. The one which we have is the CADASIL. Is the common one compared to the CADASIL because it is autosomal dominant, associated with subcortical infarcts and leukoencephalopathy. These are the patients who present with migraine. So somebody who's been having migraine, episodic migraine, especially males, and have certain amount of some dementias, and you find a lot of pseudobulbar signs when you examine. You might find the jaw jerk being brisk, or maybe having palmomental reflex, or you may get plantar extensa. These are the patients who are the multi-infarct states, and this has a strong familial inheritance related to chromosome 19. Drugs, large number of drugs, not only the illicit drugs, you could have oral contraceptive pills, steroids that we use, various immunological agents, all of them can get stroke. Migraine we'll be discussing later. Infections, I'm just going to deal a little bit about in detail because these are common. Number one is HIV. The rising in HIV. HIV per se can cause stroke due to the vasculitis that is there. All of you know HIV is a prothrombotic state. So it enhances the atherosclerosis. And you may have opportunistic infections that can come in HIV. Be it tuberculosis, histoplasmosis, toxoplasmosis, primary CNS lymphomas. All of them are prothrombotic and they can cause stroke-like episodes. So it's very important. So HIV patients can get stroke, HIV can get space-occupying lesions. We have to evaluate thoroughly. Imaging is needed to differentiate them. TB and stroke. In TB meningitis, as high as 57% of the patients can develop stroke. Now, very importantly, this is a important thing. That's why in TB meningitis, we put the patients on aspirin and even steroids in the beginning. Aspirin is recommended because as high as 57% of them can have some deficits, usually pertaining to the basal ganglia region, and they have some sort of a pseudobulbar pattern that could be seen. Arteritis could be secondary to various cytokines like TNF, VEGF, or MMPs. The prothrombotic state per se of tuberculous meningitis can worsen after starting the anti-tubercular therapy. That's why steroids are added. And aspirin again reduces the mortality and the morbidity also can be reduced. So it's recommended to start aspirin also. So we have a large amount of studies that have been done. And the only problem is how long to continue because these are young patients. And for tuberculous meningitis, you can start them on aspirin. You have to continue it for lifetime. So that's the side effects of aspirin would mount later. We have certain other inherited diseases like Snedden's, Fabry's, MELAS, that's the mitochondrial encephalopathies, lactic acidosis, and stroke-like episode. The HANAC, that is the hereditary angiopathy, nephropathy, aneurysms, and muscle cramps. The RCVS, reversible cerebral vasoconstriction syndrome, and migrainous infarction. So these are the non-inflammatory arteriopathies that could be there. As we said, there are the well-documented risk factors that have been described as early as 97. I showed you the article earlier where we had the modifiable, non-modifiable risk factors, which we have already described. As late as 2018, we had a study which specifically said the risk factors could be further defined as The modifiable risk factors like tobacco smoking, physical inactivity, hypertension, the dyslipidemias, obesity, diabetes, and the cardiovascular disease. The less well documented modifiable risk factors, high risk alcohol consumption, migraine, sleep less than 6 hours, and obstructive sleep apnea. So these are also potentially modifiable risk factors which we have to consider. So once we have known the etiology and what is the variety of diseases that we have looked for, we have to make sure that we investigate and point out the diagnosis. That is most important for us. So a thorough history, a family history, the drug history, other systemic involvement has to be done. Examination not only has to pertain to the nervous system, you have to do a thorough general and other system examination to look for clues which can help us to label down the diagnosis. And appropriate investigations have to be done. As I've told you, the neurological examination is mandatory. The carotid bruits have to be examined. Vasculitis, you have to auscultate the other vessels also. A subclavian bruit would indicate Stachyassus. A renal artery bruit could indicate fibromuscular dysplasia. Cardiac examination has to be done. You have to auscultate, you have to check the pulse, you have to check for the apex pulse deficit, peripheral pulses, whether they are present or not. Certain dermatological and ophthalmological findings could be characteristically seen in some syndromes, like you have the Caféole macules, which could be seen in NF, or it could be seen in neurofibromas. You can see that. Splinter hemorrhages, if it is present, it could suggest an infective endocarditis. Eruptive xanthomas are seen in familial hypercholesterolemia. A premature arcus, you could make out that. Tuberous sclerosis can be associated with atrophy of the optic. Hamartomas can be seen in the eye in tuberous sclerosis. A dislocated lens could say that there is Marfan's, and that could be associated with aortic root dilatation, could produce aortic regurgitation, embolism. Angioid streaks, commonly associated with pseudoxanthoma elasticum. You can see that chicken appearance of the skin that you get in pseudoxanthoma elasticum is very, very characteristic. Again, a very important cause of stroke in young. So we have to look at the general examination, the clinical pertaining to the nervous system, the vessels, as well as a thorough systemic examination. Supposedly you have a splenomegaly, you would be discussing with possibly a myelofibrosis or a myelodysplastic syndrome. If there are lymph nodes, it could be HIV, tuberculosis, or a malignancy. So a thorough examination will help us. Once we have arrived at a diagnosis, the protocol for management is similar to what it is there in elderly stroke. So you would want to do a MRI, a diffusion weighted MRI, to rule out ischemic stroke. For a hemorrhagic stroke, a CT would suffice. And once you're diagnosed a hemorrhagic stroke, you would do an angiography. Once it's an ischemic stroke, you would want to see whether it's a thrombotic or embolic. So an ECG, echocardiography, specifically a transesophageal echocardiography, very important for diagnosis of PFO or an emboli, which is located in the arterial surface there. Okay, you would be requiring a TEE. Hold monitoring to pick up the arrhythmias, and then CT angio or an MR angio to look at the vessels. And based on the further evaluation, you might require to do various blood investigations that are needed. So as we have already discussed, the CT or the CT angio or an MRI stroke protocol, the diffusion weighted image is very, very important, and perfusion scans may be required. Digital subtraction angiography may be required, especially when you are discussing about the various arteries. Transcranial Doppler, very important. Look for the various vessels, the carotid, the vertebral. Sometimes you can even look at the retinal arteries, etc., and that can help you to know the status. A transesophageal echocardiography. Now, this is one investigation which is not done so often. It's not a very, very difficult investigation. It is through an endoscopy. You pass the probe and you look at the posterior surface of the heart. It gives a large amount of information for us, which would help us in diagnosing various diseases. Agitated saline contrast, along with doing a echocardiography, either a TE or TE, will help us to know the septal defects, or even it will help us to make out the PFO that could be there. So as I've discussed, what is the advantage of doing a transesophageal versus a transthoracic? If you see that the LV aneurysm, LV dysfunction can be easily diagnosed by a thoracic, but for all the rest, left atrial thrombus and ASD, PFO, atrial septal aneurysm, myxoma, mitral valve vegetation, and aortic dissection, transesophageal is any day better. Aortic dissection, transesophageal echocardiography only picks the transthoracic, does not. So, especially in stroke in young, if you're suspecting an embolic stroke, please make sure you do a transesophageal echocardiography, and that will be helping us. So, once we have done that, and then that's when you go for the next level investigations. If it's a thrombotic, you would do workup. If you are saying, then that's where you have to possibly do the entire panel of various prothrombotic. The problem that remains is not that every patient we will get a positive result, and sometimes you might get multiple things being positive. So there is a double-edged sword when we order the entire prothrombotic panel that would be there. Also, very importantly, you have to understand that whenever an acute thrombosis happens, or the patient has been started on anticoagulants, the values or the levels of various prothrombotic protein C, protein S, antithrombin, all those things may vary. So doing the test is mandatory for diagnosis, and sometimes you may get it as a negative, but does not rule out the disease. So that's what you have to remember. But yes, vasculitis test, maybe an ANA, ANCA, APLA is mandatory whenever you're suspecting a vasculitis, especially in a female patient. A prolonged cardiac Holter is mandatory there. And as I told you, transesophageal echocardiography is must whenever you're suspecting an embolic stroke. And later, if all these are negative, then possibly we'll have to do a genetic workup for certain of the diseases. CSF, not in all cases, but sometimes it may be. So this is the workup of stroke in young. It's available in your NEJM 2016. The reference there. This is the classical, this traditional way that we have to look for. As I told you, you have to do a comprehensive diagnosis because the causes can be rare. So APLA is mandatory, lupus, ANA is mandatory, HIV ruling out is mandatory, VDRL is mandatory. All the rest is plus minus, cryoglobulins, toxicological screening, CNS infection ruling out, homocysteine, antithrombin, protein C, protein S, factor V laden mutation, the G2 0210A mutations, that is for your prothrombotic states, may not be done routinely. If you're suspecting a sickle cell disease, you would want to do a HB electrophoresis, and sometimes ophthalmological conditions can be diagnosed by looking at the fundus. That can be done in all patients. VDRL and HIV has to be done. The CSF, especially in conditions like Lyme's disease, though not common in India, in the West possibly Lyme's disease is a very important disease, and they do mandatory CSF for that. And infective endocarditis also has to be ruled out. Coming on to a few case scenarios that I'll be discussing of stroke in young pertaining to India, our subcontinent, and we think it is rare, but it is not actually rare. Only thing is we either do not evaluate it to that level to find out the cause. So these are a few of the diseases that we have. So here we have a young patient who has come with stroke, and these are the images that you're seeing there, and you're seeing the hyperintensities there, and what you're doing, a digital subtraction angiography, that gives us the diagnosis of dissection. So again, a very important disease is the dissection, both carotid as well as the vertebral artery. Traditionally, based on literature, it is supposed to be around 2.5 per 100,000 VR. But what you have to understand is the recurrence rate is not, as per literature, they say it's 1% per annum, but it is much higher. And first of all, if you diagnose it in the first time and treat, the recurrence rate, once it recurs, the chances of survival is very, very, very poor. Commonly present with neck pain and Horner syndrome. So if a patient comes with a unilateral neck pain with a unilateral painful Horners, that's where you're supposed to diagnose a carotid dissection. And almost 70% of them will develop stroke eventually with multiple cranial nerve palsies based on the location where it is. And the patient may have pulsatile stenosis. You might be able to get a bruit on the skull, and sometimes you may have scalp tenderness there. The diagnostic is an MRI angio or a CT angio, and it requires a specific. So you can see here the dissection very clearly. the carotid dissections and resulting in the bleed there. You can have vertebral artery dissection also. Again, if the vertebral artery dissection occurs, it generally presents with brainstem syndromes, most commonly lateral medullary syndrome. Sometimes it can produce occipital, bilateral occipital ischemia. Spinal cord ischemia, very, very common with vertebral dissection, and they can sometimes present with epidural hematomas also. So dissections can occur in both systems, and you have to have a high clinical suspicion, and you will have to be very much careful in giving the prognosis because the chances of recurrence are high, and once it recurs, we may not be able to do much. Coming on to the second case where the patient presented with some sort of features like a stroke, and an imaging showed something like an SOL that you can see there, and you see that the venous sinuses are full there. So this is a very, very common thing that we see. All of you would have also seen in your colleges or schools. That is the venous thrombosis. Again, a very common thing, and in India we do have a large number of venous thrombosis that come, and they approximately occur to around 5% of 0.5 to 1%. That's the literature, which says that 1% of strokes due to that, but it is much, much more common. 50% of strokes in Indian women are related to pregnancy and puerperium, and 95% of them is due to CVT. This was described way back in 1997, but still we do not give that much of importance to it. Please remember, venous stroke, the CVT, is a potentially reversible cause. And if you do not treat it adequately, you do not start anticoagulants pretty early, the patients can develop severe cerebral edema and can die because of that. So it's very important for us that we have to identify the cortical venous sinus thrombosis, treat it fast, and you can have a complete recovery. Because again, remember, the arteries are normal here, the venous, so the deficit is very, very minimum in these patients. They only come with headache. So the headache is the most common feature that could be. So if you see, there are 3 age-related CVT peaks. In young children, it's seen usually due to diarrhea. In young females, sorry, in infants, it is seen due to diarrhea. In young females, it's secondary to the OCP and pregnancy. And elderly, it's secondary to a malignancy. So that's all you have to remember. It can be occurring at any age. So various hypercoagulable states which you have discussed, all of them predispose to that. Pregnancy is by far the most common. And very rarely they present with focal deficits. They generally present with headache, altered sensorium and seizures, but can have hemiparesis and aphasia, and psychosis, etc. can also be present. A simple CT contrast can show you the empty delta sign. You can see that very clear here. That shows that the absence of flow through the sinus that results in the triangular shaped defect at the posterior aspect of the superior sagittal sinus. That's the empty delta sign, which is very pathognomonic. And then you can do a angio for that. So the most common manifestation is headache, followed by papilledema and seizures. Focal signs can be seen around 40%, but more than 80 to 90% of them would be headache and seizures. And the cause, puerperal peripartum, accounts for almost 50% of the cases, the OCP accounting for around 24% of the cases, and it could be associated with hypercoagulable states and infections also. So females predominance, 69% is females, and very important, once you have a diagnosed venous thrombosis or maybe an arterial thrombosis in young, when to investigate for an inherited thrombophilia. So again, remember, the heparin, once we start, can be associated with up to 30% reduction in plasma levels of antithrombin 3. So just because of the heparin, the levels can be decreased. Warfarin produces reduction of protein C and protein S. So when the patient is on warfarin, to test them is not actually adequate. Therefore, testing is to be done when the patient is fully recovered from the acute event and is off anticoagulant therapy for at least 2 weeks. At least 2 weeks of stopping of the anticoagulant therapy. Only then we should investigate these patients for the inherited thrombophilias. D-dimer, which is a very important marker that we use for pulmonary thromboembolism, is it useful for the same venous in the brain? So a positive D-dimer levels has a sensitivity of 71.17% and a negative predictive value of 99.6%. So it has a good important role in a patient with CVT also. So again, Is standard heparin better or low molecular weight heparin better? Other than renal failure, please remember, other than renal failure, for all other purposes, the low molecular weight heparin is better in many ways. Standard heparin, the side effects are a little more. So the low molecular weight heparin has much more easier, and these patients might have to take it for a longer time. And low molecular weight heparin twice daily or sometimes once daily is sufficient, whereas the standard heparin might be required 4 to sometimes more times daily also. Warfarin, as we said, has to be given. The newer oral anticoagulants have come up, except for your cardioembolic stroke, the rheumatic heart disease, which is there. All other conditions, you can give your novel anticoagulants also. So warfarin is also importantly have to be connected. Coming on to the next case where you have a female who has presented with headache and hemiparesis, and this is what you're seeing there. You're finding a large hemorrhagic lesion there, which is a hyperintensity of the vessels you're seeing there. And this, when you classically see, you're seeing the vessels are very much attenuated. It looks like a puff of smoke. This is moya moya. We do find a large amount of series of moya moya. You have, I think, one coming from the Nimhans, and you had a large series that is coming even from Jaipur. So moya moya is a common disease, which is nothing but a vaso-occlusive disease characterized by abnormal vasculature at the base of the brain, and it is occurring at the circle of Willis, and the terminal branches of the IC are predominantly involved. So there is a fibroblastic proliferation which has certain genetic as well as an infection base. Various staging system. This is a theory question that's asked for postgraduates. You have a it was first described in Japan. So the staging system was given by Suzuki and Takakau. So various stages are there, and you can read about it. I won't go into the detail of that. So patients usually come in the first decade, and in children it's usually TIAs and ischemic. In adults we get hemorrhagic strokes. It manifests both. So again, the classical appearance is seen on a CT angio, and that's how we diagnose it. The puff of smoke appearance, you can see there, and the classical creepy IV pattern. You can see that it's like a IV that is creeping on the wall. That's the pattern that you get. Very characteristic. The creepy poisoning IV on tome. Very, very characteristic on the even weighted images. You can get that, and that's diagnostic. But the DSA is the procedure of choice, and based on that only you can make the diagnosis of moya moya disease. Moya moya disease is associated with other conditions. Common conditions which are common in India: neurofibromatosis, Downs, thalassemia, and even acquired diseases like tuberculous meningitis, leptospirosis, drugs like phenobarbital, etc. can also be associated with moya moya cytofeatures. So it's not just that a single disease may be present in a single patient. You may have multiple diseases which could be presenting as stroke in young in patients. That could be. So it requires a clinical suspicion, and you might require to. And again, it has a good. You can do a therapeutic antiplatelets, medical heparin, and then calcium channel blockers, or you might require a surgical bypass of the MCA when you find there. Various surgical procedures are there which can be used to treat this AV malformation, and it has rewarding results also. But basically, we have to diagnose. A few words on migraine and stroke. Large number of studies have been done from the beginning to now. As I told you in 2016, they've said migraine, the lifetime history of migraine is a potential risk factor of stroke. So supposedly, patients who have had migraine and the patients who have not had migraine, the chances of stroke is doubled in the patients who have had migraine, because migraine per se is a vasculitis. It's a vascular inflammation sort of thing, pathophysiology that's going on. Coming on to the patent for aminovel, which I told you, is nothing but a remnant of the fetal circulation, where it acts as a shunt, like a septal defect. Traditionally, it was believed that PFO is not a functional entity, it is just present there anatomically. But now we have understood that this is one of the important causes for cryptogenic stroke and some sort of an embolic stroke. And again, remember, the prevalence of PFO in adults is as high as 35%. So the chances of every third person in this planet or in this world having a PFO is so high. So the chances of stroke is much higher with PFO. So that's something which is come up and we have to be aware of. And PFO can be easily diagnosed by a transesophageal echocardiography. You have to understand that the transthoracic may not be useful, and large number of case reports are there. Here you can see a very characteristically a thrombus that is sitting at the PFO, and this is was picked only by a transesophageal. It was not picked up by a transthoracic. So after discussing all what we have told, the etiology, the clinical manifestations, the approach, and the common diseases that we are seeing in India, let me just wind up by saying about the global burden of national stroke risk, which is a global study done all over the world. Almost around 800 investigators. I was one of the investigators in that, and where they compared various types of stroke and the etiology of strokes that have been there. And the global burden of strokes has increased right throughout. From 1990 to 2000, there is a 85% increase in the global burden of stroke. Death due to stroke is increased to around 43%, and the disease, the number of years that is lost due to stroke has increased to 32%. So it's a large amount of thing that's happening with stroke. So from 1990 to 2019, when we are seeing, there is a exponential increase in the number of strokes that we have seen. The same is with the stroke in young also. In stroke in young also, the percentage which was traditionally believed to be around 32%, now they say the total stroke percentage can be as high as 40%. That article is still to be published, should be published somewhere by this year end, where the percentages of young stroke is seen. And so that's the burden of the disease. And this is the various patterns. And India is there for all the types of strokes. This is from the article which I told you, the GBD article. And you can see that we have a large amount of strokes that is increasing world over. So if you see the various causes, if you have told, which I have already discussed, in this study also which we did, the high systolic blood pressure, the high BMI, high plasma glucose, the sodium increase, the smoking, presence of CKD, diet low in fruits, alcohol use, and certain things like temperature also had a major role in various pathogenesis of the stroke. So in conclusion, I would say that young stroke is not rare. Young stroke is on an increase. It is very important for us to understand the etiology, identify the etiology, evaluate the etiology, and make sure the recurrence does not happen. And some of the strokes in young have very gratifying results because you may be able to treat the disease completely. Prognosis is very good, but the chances, the amount of morbidity that remains, the patient has to live for a longer years because it's young. So that we have to take care of. So that is what is in conclusion. Any doubts or clarification?
Thank you so much, sir. Thank you so much for a very interesting topic that you have picked for the today's webinar. And I'm also having some very interesting questions for you, sir, which I'll just depict immediately. Just hold on. Yeah, so there are a few questions, which is bottom up or top down, which approach is effective in stroke patients?
Just a minute. What is the question you said?
Question is bottom up or top down, which approach is effective in stroke patients?
Remember, bottom up and top down is all for chronic diseases, be it asthma, be it rheumatological conditions where we start slow and go slower. Possibly we can use one by one. Stroke is not a disease like that. Stroke in MI is you have to use the best of the treatment and at the fastest. There is nothing like bottom up and top down in stroke. You will have to identify the type of stroke and you will have to manage it immediately. So there's no bottom up and top down in stroke. These are acute conditions where we have to use it. We have to use the complete resources that we have. There is no one after the other.
Okay. So another one is what are early screening tests to decrease mortality in young strokie?
So again, we have to assess the risk factors. Most important is the family history of risk factors. These are not modifiable. And if there is a strong family history, those patients have to be screened. be it family history of stroke or family history of cardiac diseases. If anybody has that, then definitely these patients should occur screening. And if there is an autosomal dominant pattern, be it Cadacil or Sneddon's or Caracil, one of them, then such patients have to be screened. Otherwise, there is nothing like screening for stroke. As you age, maybe after the age of 40, there is a standard screening for diabetes, hypertension, dyslipidemia, etc. The same can be done in younger patients, but there is no limit of how to screen and what to screen. Again, remember the etiology is quite varied and quite different. You have an entire panel of investigations, and if you end up doing all these investigations as screening, we might find certain not so relevant factors, and then we go behind that. So it's nothing like screening for young stroke. We have to be aware that this can occur, and if possible, family history is there, such patients have to be definitely screened.
Okay. Another one is, sir, what are the risk factors causing lacunar stroke?
See, lacunar stroke basically is because of the lipohyalinosis, and hypertension is by far the most important risk factor. Whatever be the cause of hypertension, lipohyalinosis occurs, and lacunar stroke is secondary to hypertension. Embolic strokes also produce lacunar strokes. So both hypertension as well as your embolism are the causes for lacunar strokes. The classical thrombotic strokes are not lacunar.
Okay. So another question is, when to start anticoagulation in cardioembolic stroke?
See, cardioembolic strokes, if it is cardiac and AF is there, anticoagulation has to be started immediately, with the exception based on the size of the infarct. Supposedly the size of the infarct is more than 5 to 6 centimeters, which is said, or it crosses the midline, or there is a large amount of edema, the chances of hemorrhagic conversion is higher, or there is any other contraindication, we have to start anticoagulation immediately. There's nothing to wait. You have ruled out a hemorrhage, anticoagulation has to be started immediately, and it has to be continued for life if it's a cardioembolic stroke.
Okay, sir, now last two, three more questions that will go. Okay, saying, can you explain the investigative part in case of hypercoagulable conditions related strokes?
Yeah, I've already given you the list of investigations which has to be done. If it's a female patient, ANA, APLA has to be done. Otherwise, in all other patients, HIV has to be ruled out, tuberculosis has to be ruled out, syphilis plus minus has to be ruled out. And for the other prothrombotic states, I have already given you the rider there, that when the patient is an acute stroke, the values will be erratically, it may be low or sometimes high. And once you start on antithrombotics, we cannot do this evaluation because the factor levels decrease by around 30%. So you can do the entire panel. I've shown it in the slide. Entire panel is available, but to interpret the results is not so very easy once the patient is in having acute stroke or is on antithrombotics. But the basic thing that has to be done is an HIV ruling out, tuberculosis ruling out, and in females, APLA and ANA to be ruled out.
Okay. Last three questions, sir. Which is better, PFO closure or long-term OACS in a patient with stroke?
PFO closure, see, as I told, the PFO is much common, and if you give a chance, all our cardiologists would be happy to put in their balloons there and close it, so they will get a large amount of patients for that. Device closure can be done, but whether it is warranted or not, we are not sure as of now. Though, as we said, the entire pathogenesis of cryptogenic strokes is through PFOs, and what is the level and I cannot offhand say that it would be better to close them or not. Anticoagulants, the newer oral anticoagulants do not have that much of a bleeding risk, nor they require monitoring. Only problem with the newer oral anticoagulants is the cost factor that is there. So it's not that we can put them for lifetime on anticoagulants. So if you have to weigh the risk between the lifetime anticoagulation and the PFO closure, I think PFO closure would be better, would be more warranted, and possibly in the long run will be more less expensive compared to the side effect profile as well as the long-term activity of the anticoagulation that we have to give.
So if PFO has such a high prevalence, should a routine surveillance be placed for the same?
It will eventually come. Transthoracic echocardiography will be a standard test which will be done for practically all cardiac patients as well as patients with family history of strokes, etc. and possibly routinely it is coming up a lot, the transesophageal echocardiography, and maybe there will get some cardiac MRI, etc. with good images, we may be able to diagnose it. It will eventually come to the screening level itself.
Okay, so I think second last question, like a lot of questions are coming up, sir. Is it any possible in a young patient to have both venous and arterial stroke or simultaneous venous and arterial strokes?
Yeah, certain conditions are prone to develop that. Okay, like you have a patient with APLA syndrome, a patient with HIV, a patient with tuberculosis, patient with hyperhomocystinemia. All these are risk factors for both arterial and venous thrombosis. So you can have it. Especially you could have this in patients with HIV sometimes. You do find arterial strokes and venous strokes commonly. It can be existing for. But we have a few diseases which can occur together. The treatment is same like a venous stroke plus aspirin.
Okay, the last question is, how can we treat venous thrombosis due to recurrent central INE insertions in internal jugular vein?
Okay, whatever be the cause of thrombosis, the treatment is anticoagulation. So anticoagulation has to be done. If it's a provoked anticoagulation, like we have put a central line there, then possibly the duration of anticoagulation might be 2 to 4 months. If it's an unprovoked thrombosis, the duration of treatment is minimum 1 year, and then you have to take an assessment for what is the risk and prognosis. And sometimes if you don't find a cause, then you might have to continue for a much longer time. And if it is cardioembolic or there is any cardiac soak that we have found out, then possibly it is lifetime anticoagulation. For venous, secondary to the thrombosis, secondary to all your lines, it has to be started immediately and continued for at least 2 months.
Sir, how is thalassemia related to venous thrombosis in young?
Yeah, thalassemia, you remember thalassemia and sickle cell anemia. What is found now is we have the mixture of both. It's not pure thalassemias or pure sickle cell anemias that we do find. You have sickle beta thalassemia that's commonly seen. And because of that, there is some sort of a hypercoagulable state. And remember, these are all conditions where there is anemia and there is a constant state of bone marrow stimulation. And that can also be acting as a prothrombotic state. So that's how sickle classically. So if beta thalassemia is having thrombosis, definitely we'll have to rule out sickle in that. Sickle beta is a very common combination that we get.
Okay, great, sir. Maybe just last question I'm going to, some more questions keep coming, sir. Is it still beneficial to use the classical bridge therapy with Clexane and warfarin, or should we use NOAC now?
See, other than the cardiac rheumatic heart disease, that is one no for, you cannot use novel anticoagulants. Or maybe a pregnant lady. If there is a lady who is pregnant or going to get pregnant, that's where we cannot use NOACs. Otherwise, we have to use, otherwise for all other conditions, we can use NOACs. And acute thrombosis, for the NOACs to work, or warfarin would take at least 4 to 5 days. NOACs would act much earlier. But Clexane has to be there. The heparin or the Clexane has to be started, especially for warfarin. But if you want to start NOACs, definitely can be started straight away. Maybe the duration of bridging may not be that long. You may directly start NOACs also. But again, you remember whenever you have an acute stroke there, or a DVT is there, or a venous thrombosis is there. So to not start a patient on heparin or low molecular weight heparin and directly start NOACs. We know that NOACs will work, NOACs will act fast, but still we require to act faster than that. So possibly you require parenteral agents for that.
Okay, so the last question only, in case of venous strokes, if simultaneous thrombosis and venous hemorrhages is present, then what is the role of anticoagulant? And if large venous hemorrhage is present, then also we have to give LMWH or heparin.
So again, remember, venous strokes, hemorrhage is a rule. There will be hemorrhage in venous strokes. CVT will have hemorrhage, but the treatment is anticoagulant. That hemorrhage is not due to a vessel leaking. Remember, the hemorrhage which occurs due to arterial is a rupture of the vessel. Venous hemorrhage is not due to that. The treatment is anticoagulant. You will have to give anticoagulants, either of low molecular weight or standard heparin, both can be done. Both can be used. There is no head to toe which is better. You will have to give anticoagulation. If it's a venous stroke, however big the hemorrhage is, you will have to give the anticoagulant. Now again, remember the site, supposedly it is in a critical site and you have a hemorrhage and there is an edema. The risk has to be weighed. You will have to discuss it with the patient that hemorrhage is there, but the hemorrhage is due to venous infarct and the treatment of venous infarct is antithrombotic. There is a chance of the hemorrhage worsening, but if it is a pure venous infarct, the chance is much lesser. But if the bleed is at a very critical area, there is a chance that it can cause death also. That has to be discussed. But please remember, the hemorrhage in CVT is not a contraindication for starting anticoagulants. You will have to start anticoagulants. Anticoagulants are the treatment for hemorrhagic CVT.
So the last question only I'm asking that how to start anticoagulants in patients already on aspirin.
Aspirin has nothing to be dealt with anticoagulants. Anticoagulants and antiplatelets are totally different. Antiplatelets are useful for long-term prevention of arterial thrombosis. Okay? When there is an acute thrombosis which is happening, we require anticoagulants. Antiplatelets will not work. Even the parenteral antiplatelet agents won't work that much. Anticoagulants and antiplatelets, there is nothing to be mixed about. Patient on aspirin, you will have to start on warfarin or anticoagulants. That doesn't make a difference. You don't have to think. If there is a bleeding or something, then if thrombocytopenia or something is there, then possibly we'll have to be taking a little weighted risk, because thrombocytopenia, aspirin has to be stopped. Thrombocytopenia can occur due to heparin also, so we cannot use heparin such. In such cases, you can give factor 10 inhibitors. Fondaparinux can be.
Okay, the last one is can P selectin elevated in patient with hemorrhagic stroke?
I couldn't get that.
It's can P selectin elevated in patient with hemorrhagic.
B-selectin. That's what is the thing.
Selectin.
B-selectin be associated with increased stroke. I'm not aware of it. Actually, I'm not aware of this.
Okay. Well, thank you so much, sir. Thank you so much. It's such an interesting session that I can see people are still, hooked up with us with all the queries that they have raised. And it's a very interesting topic. As far as young is quite increasing in India as well as other developed countries. So thank you so much for your time, Dr. Archit. Thank you so much for taking your time out. And I'm also thankful to all the participants, for attendees for the session. And as a Walters Kluwer, we'll keep bringing out such more sessions in the coming future for sure. Thank you so much, sir. Thank you so much, Dr. Archit.
Thank you.